we will get started. It's my pleasure to introduce Dr. Daniel Hall. Dr. Hall is a staff psychologist in Mass General's Department of Psychiatry and an assistant professor of medicine at Harvard Medical School. He serves on as faculty in a number of programs, including the Health Promotion and Resiliency Intervention Research Group, the Health Policy Research Center at the Mongan Institute, as well as the Behavioral Medicine Program, the Benson Henry Institute for Mind-Body Medicine, and the Cancer Center for Psychiatric Oncology and Behavioral Sciences at MGH. He earned his PhD in clinical psychology at the University of Miami, completed a postdoctoral fellowship in the behavioral medicine program with MGH Psychiatry, and finished another postdoc in integrative medicine research through Harvard Medical School. And he holds a certificate in clinical effectiveness from the T.H. Chan Harvard School of Public Health. And he's been a great collaborator for me on some of our research together. And so it's a pleasure to introduce him. He's going to be talking about approaches to managing uncertainty, stress, and related symptoms. So thanks so much, Dr. Hall.
Hello, everyone. Great to be here. And thank you for that introduction. I just want to say happy Saturday to everyone. It says a lot that you're here today, and it's a privilege to get to speak with you all. I just want to acknowledge a couple of the themes that I heard earlier today. As Zach mentioned, I'm a psychologist, and so I pick out some of the psychology-related terms. You know, I heard caregiving, I heard cocooning with COVID. I've heard discussion about side effects, managing side effects, especially with prednisone, but other medications. Heard about managing sleep and stress. And so I'm hoping to address some of these topics throughout this morning's talk. Just want to share, I provide scientific advising for GoodPath, but this work does not pose any conflict of interest with my research or clinical work. So I just want to begin with a little bit of theory, but I want to make it very, very salient and concrete for all of you, because you probably didn't come to hear a psychology lecture. But after diagnosis of a chronic or life-threatening illness, there are a variety of things that can generate uncertainty for any type of patient, but in the context of rheumatological illness, these things can be very, very salient. I find it's especially helpful when talking about things like uncertainty, just to introduce a few terms. Uncertainty can feel very ambiguous and big. So when we're talking about uncertainty, these four terms can give a little bit of clarity. There's lack of information, so when patients don't know who or when to turn to for help. And oftentimes this can be addressed by looking up information online, if that information is available. It isn't always, or reaching out to your doctor. But there are other forms of uncertainty. In some ways, lack of information is the easiest to address. There's ambiguity whenever there's conflicting information. So maybe your doctor tells you one thing, in a forum, you hear something else. Whenever there's a clash of information that generates ambiguity and uncertainty, there's complexity, right, in managing the medical system, and we've heard a little bit of that today. And then unpredictability about the future. None of us are able to predict the future. I haven't met anyone yet who's been able to do that. And our inability to do that, just doesn't sit well for us a lot of the times. And this uncertainty gets framed oftentimes, not always, as fear. Fear of illness returning or progressing. And in the context of rheumatological illness, this has been studied a little bit, not a lot, in terms of fear of flare exacerbation, fear of immobility. This has been studied a lot in some other illnesses. And so, especially in cancer, a lot of my research does work with cancer survivors. So I'm going to draw on some of that work in my talk today. With cancer, this comes up as fear of cancer recurrence or fear of cancer progression. But you could see with many other diseases, including cardiovascular disease, MS, HIV, these fears are really salient. There's a little bit of work we've started to do at MGH to understand and document uncertainties and, kind of the big so what, like, so what is of having uncertainty? Well, what we learned from a survey that Dr. Wallace and I conducted, and I think a few others in this room had conducted at MGH, a survey study, just to understand, again, the correlation of uncertainty and things like depression, anxiety, and sickness impact. And what I want to share in the boxes that are highlighted, we looked at these associations in a few different rheumatological illness subgroups, But among the ANCA vasculitis subgroup, which included 41 patients, we saw on average very, very high correlations with, so uncertainty was associated with depression, uncertainty was associated with anxiety, greater uncertainty was associated with greater sickness impact, meaning the impact sickness has on your day-to-day functioning. I just want to point out these correlations weren't the same for all subgroups. Okay, this is not a one size fits all. We see this also with cancer, different types of cancers and prognoses, right? So cancer is not one illness. Rheumatological illness certainly isn't one bucket. And we're seeing here that vasculitis patients are identifying, at least at MGH in the sample, uncertainty is a major, major stressor. Going back to the work that I've mostly been doing up until fairly recently and connecting with Dr. Wallace and his team. As I mentioned, it's focused on cancer recurrence. And I just want to highlight this diagram. This is a diagram that we published in a supportive care in cancer, Journal of Oncology Practice, and is really at the core of a lot of our programming in psychology at MGH, where we think about physical symptoms, health behaviors, and emotional distress as interrelated. Probably, I won't ask you a quick show of hands, but you might think for yourselves the way that your body, your mind, your stress levels interact. In some ways, when things are bad, it can feel like it's all bad. But by unpacking it in a model, it gives us tremendous leverage to think about targets of intervention. We can't always just go into someone's brain and help them feel less stressed by turning on and off a switch, but we do have tools for managing patterns of thoughts that are interfering with their quality of life or their ability to engage in healthcare in a meaningful way. What we see is fear of recurrence isn't just a challenge, and uncertainty isn't just a challenge because of the distress, but it leads to things like body checking, things like greater utilization of healthcare, things like more health risk behaviors for patients who may have a smoking or alcohol history. When they're upset or distressed or scared, they may turn to maladaptive behaviors for coping. And these, of course, can link back and worsen physical symptoms. In the work that I've done, again, I'm hoping to leverage a lot of this work with cancer survivors into the rheumatological and vasculitis populations. What we see for cancer survivors is naturalistically, they're utilizing a variety of practices for managing these fears on their own. So the American Cancer Society has surveyed cancer survivors in the United States for several years, asking about their greatest concerns, as well as utilization of different healthcare practices. And for cancer survivors, they're utilizing mind-body practices quite a bit. And among those utilizing these practices, they're reporting benefits of greater stress management and reduced fear of recurrence. So I'm very interested to learn, well, what are these mind-body practices, and can we combine them into an integrative, cohesive intervention, and ideally teach these skills to patients with rheumatological illness. This slide is way too busy. I probably should have cut it before coming in today, but I want to share we're following a sequential model for building this intervention that's based on systematic review of literature, a lot of pilot testing, and then finally full testing in an efficacy trial. What we've learned is that mind-body interventions work. They work well with efficacy for reducing fear of recurrence, that interventions typically involve cognitive behavioral skills, so teaching things like tools for managing stressful thoughts, or behavioral skills for engaging with things that are really scary or difficult, but also relaxation skills and meditation techniques. And when I published this in 2018, there was very little literature on whether or how to integrate things like meditation or relaxation training into protocols for managing uncertainty. It just wasn't integrated yet. And so at MGH, we have adapted an existing multimodal mind-body intervention that we offer through the Benson Henry Institute. This is a program that's been developed over the last 35 plus years. It's called the SMART 3RP. It's a mouthful, but it stands for Stress Management and Resiliency Training. And what was great about this program is it included, I'm going back one slide, it includes all of the components, all of the core skills of interventions that my colleagues and I have found work well for addressing fear of recurrence. It includes CBT skills, includes meditation, includes relaxation training, and some training in positive psychology techniques that teach creativity and humor for managing things for dealing with things that can't be controlled. So it included this information as well as education about sleep, nutrition, and physical activity. So we've adapted this manual to address fear of recurrence. I won't go into the weeds about that adaptation process, but I just wanted to share we're moving the needle on fear of recurrence among cancer survivors, and people who are completing this intervention say it's enjoyable, it's acceptable to me. We were worried, would cancer survivors not want to talk about fear in a group program? If they were really concerned about this, would it be the last thing that they would want to sign up for? But it hasn't been the case at all. It's been a validating experience for a lot of them. I want to share some quotes. And then on the next slide, I'll share an example of a participant who went through our program and what types of skills resonated with her. These quotes, I think they highlight a variety of changes that can happen when you're exposed to mind-body techniques like meditation, relaxation training, and cognitive behavioral therapy. There were some cognitive changes, changing the way they're pointing out negative thoughts and how these can affect our body, and doing meditation was a helpful skill for one participant. Another person was getting caught up in statistics. Sometimes we joke around, this is like consulting with Dr. Google. Actually, on the next slide, a participant, Maria, talks about this, consulting with Dr. Google. And in the moment, it sounds like something I certainly can relate to. Many patients who I work with, they're curious about their symptoms or the state of their illness, and so they go online and look. But what happens is it generates uncertainty because there's more than one opinion, and then you're left having to reconcile that. Emotional changes and existential changes came up as well. I want to point out, if you're curious to hear, we had an incredible opportunity a few years ago to give a grand rounds on this intervention we developed, and a participant from the program came and spoke about her experience going through the program. This is recorded and available online if you're curious to see on the Osher Center for Integrative Medicine website. But I just want to summarize. Her name was not Maria, but I'll call her Maria. She discloses her full name in the video. But for Maria, when she went through our program, these were the benefits she took away. She began mindful walking and gardening. She began thinking about her thoughts, not as judging herself for being afraid or being sick, but how could she have compassion for herself when she was sick? She, as much as it was challenging for her, and it was, she practiced in our 8-week program just abstaining from consulting with Dr. Google, and then just seeing what was that like as an experiment. And through that and adaptive strategies, she found the negative was reduced and the positive was increased. So she had less insomnia, less distress, and felt more growth, more personal growth in terms of meaningful connections with others. So for her, fear of recurrence and anxiety was hand in hand with resiliency. And we're wrapping up an RCT testing this intervention right now. But I want to pivot a little bit and just say, fear of recurrence, like I mentioned, this is not unique to cancer. It just happens to be a population where there's a lot of research already. And so I'm hoping to leverage that. You'll see Dr. Wallace and I are collaborating on a project. Hopefully, maybe we'll find some funding for that soon, to develop and expand on this multimodal resiliency program for patients with systemic autoimmune rheumatic disease, or SARDS. We're calling this virtual room, and it would be a virtual mind-body intervention, also looking at fear of recurrence in a few other illness populations. What I'd love to do is pause and teach you all a few skills. So how does that sound? Does that sound okay? All right. I will not do any of these skills probably full justice, but I'd love to introduce a few skills so that this isn't smoke and mirrors. So this is drawn from our intervention framework, where again, fear of recurrence and resiliency go hand in hand. But I just want to teach 3 short skills. One for eliciting relaxation, the relaxation response. We know that when we're in a state of anxiety or fear, immediately the body is in a state of fight, flight, or freeze. And it's very, very difficult to be effective problem solvers when we're in that state. So one of the first things we do is elicit the relaxation response. One of the most powerful ways to do this is, well, there are the variety of ways to induce the relaxation response. One of the ways that we teach in our program, and again, this is from the Smart 3RP manual, are minis. Minis are very short, bite-sized relaxation techniques you could do on your own, in the car, in between sessions, etc. These could be 30 seconds, these could be 2 minutes. And these are different from maybe like 20-minute long relaxation techniques we might learn in the full program. But this mini involves mental repetition with counting paired with deep breathing. There's a variation on this. Sometimes people have heard of box breathing or 4-count breathing. If counting is not your forte, some of us, it's not, maybe physical sensation. So there can be repeated hand massage or tapping, just paired with deep breathing. And this is meant to immediately induce just some vagal tone to induce some parasympathetic tone when you're already in the state of fight or flight response. Okay, second skill, I'm sure there'll be questions, but maybe we could save that for the end. Okay, so second skill, I would like you all to worry. I want you to worry. I may be the only psychologist to tell you that, but worrying is okay. It's healthy to do, but it's not healthy to do if you're doing it while you're watching TV, while you're with your friends, while you're journaling, while you're gardening, or with your mask on, or traveling with your mask on. These are, all of those activities. You should be, in it to win it, and fully with your family, with your work, whatever you're doing. But worrying shouldn't occupy that space. Instead, we need to figure out a really smart time for you to worry. Okay, so worrying at night doesn't make sense because that will keep you up. But great times to worry include when you're walking the dog, or going, in the morning, pouring coffee, making breakfast, brushing teeth, doing a shower. Experiment with bookmarking your worries to an allocated 10-minute block. And it can be a little tricky to do at the beginning, but we have patients reporting this is very liberating, okay? Because they will worry. It's not like you can't, just stop worrying. But if you give yourself permission to do it in time and place of your choosing, it can give you a way to have a little bit more control over those intrusive thoughts. And finally, there can be a gentle meditation. When we're struggling, maybe with, worrying about flares, or thinking about medication changes, your upcoming appointment, maybe even whether or not to get your COVID booster. Maybe you're still on the fence. There are a lot of judgments that we get from well-meaning people, whether they're doctors, whether they're people in our family, whether they're ourselves. And these judgments kind of make us feel bad sometimes. They're meant to be motivating, but sometimes we feel bad for not doing them, okay? It's okay to have self-compassion. We're not perfect, we're works in progress. And it's good for us to become, our own coach a little bit with that. So we do a guided imagery practice where you just imagine yourself feeling more confident, feeling like, if I had a flare, what would the version of me that's handling that well, what would that even look like? And it may be hard to do, but this is a great skill, a practice. Again, you may not get the first time that you do it, it may not bring a revelation, but usually when people sit down a few minutes a day and just think, what would the more resilient version of me, the stronger me, the more confident me look like? And if there's an image that comes to mind, take it with you. Okay, I think I'm all right on time. So I want to cover a lot of ground today. I wanted to talk about managing uncertainty and stress and teach some skills, but I also want to leave a little bit of time for talking about sleep. Raise your hand if you have perfect sleep. Okay. Oh, wow. Okay, we have one. Okay, afterwards, come talk to me. Maybe one of the first people I met. Usually, sleep is something most of us are pretty dissatisfied with our own sleep. I do a lot of research on sleep. I'm not the best sleeper in the world, I think this is something that does vary for a lot of us. The challenge is when, it's a persistent concern, and so acute insomnia, transient insomnia is very, very common. Most of us have that, okay? And it's not a clinical problem. If you have a night or two of not great sleep a week, it's not a clinically elevated problem. Where it becomes clinically elevated is where you have 3 or more nights a week for at least 3 months of disturbed sleep. And there are ways of quantifying that. But we're talking about a pattern, right? At least 3 months of having really poor sleep. What we know is that 1 in 5 Americans would say yes to that. Work that we're doing at MGH and starting to look at some other literature, although there's very few studies on sleep and living with rheumatological illness that we're seeing. But at least some of the pilot work at MGH is showing higher rates of sleep disturbance among vasculitis patients. So it's, in other words, rather than 20%, this looks like it's closer to 26 or 27%. My guess is, we're saying that they're having trouble with sleep. And so this isn't a small issue. Having poor sleep can affect a lot of things. I have other slides that talk about impacts on our immune system, impacts on long-term physical health. But what I really want to convey is if you were somebody who didn't raise their hand, okay, about having perfect sleep, I just want to encourage you to think about that other point I made about chronic insomnia. And if you feel like, you know what, yeah, that might be me, I want to encourage you to reach out to your PCP for a referral for the gold standard treatment, CBTI. CBTI works, it works really well. It's of all cognitive behavioral therapy outcomes, things like anxiety, depression, insomnia is where you have the biggest effects of CBT. So it's endorsed by the American College of Physicians, and it involves an intake, usually 4 to 10 sessions, and you learn 5 skills, which if I'm really good, I'll cover, I'll cover in the next few slides. What I want to share is just a very recent paper, right, published this month in Rheumatology that looked at CBTI as a pilot study, or I'm sorry, this is an RCT testing the effect of group-based cognitive behavioral therapy among patients with rheumatoid arthritis. What they found were improvements, moderate to large improvements in insomnia severity, and some mixed findings, really other sleep metrics. So what this tells me is this is a really great, encouraging finding, but this tells me CBTI might need some refinement or targeting, or the delivery needs to be improved a little bit better to address these needs. Again, drawing from the cancer survivorship population, we've recently been very successful in developing a pilot program and having this published in Cancer and Sleep Medicine. We're seeing that in 4 sessions of teaching cancer survivors these skills, which I'll share with you, I promise, on the next few slides. In 4 sessions in a 1-month program, we saw clinically meaningful and large effect size improvements from T0's baseline. T1 is 4 weeks later. T2 is 1-month follow-up. And what we're seeing is compared to an enhanced usual care control, where they received a sleep hygiene handout and a referral for CBTI within our hospital. Again, very large and sustained benefits, but most importantly, we already kind of knew this. I guess we knew CBTI works, so that's not the real innovator. It's exciting to see, but to me, what's most exciting is people really enjoyed the program. I'm not used to that. I'm used to people saying, I don't know, I've been sleeping this way for a long time. I'm resistant to changing my behaviors. So we're trying to understand a little bit more about who might benefit the most. But overall, this is a great program, and we're using this now as a training model at MGH whenever we're teaching CBTI now with cancer survivors. And I'd love to explore possibilities for doing the same in rheumatology clinics. Okay. If this timer's right, I still have about 5 more minutes. So does this sound okay? We'll cover a couple of CBTI skills so that you get a sense for what this intervention entails. Okay. Again, with the caveat that each of these requires a lot of training to deliver and to learn, I'm just going to provide a very quick overview. Stimulus control is probably the pillar of CBTI. This is all about conditioning. So maybe you could tell I do a lot of teaching and I have a young kid, so sorry about this, but quick show of hands, who maybe remembers like Pavlov and Pavlov's dog with salivating and the bell, right? So this is something some of you have heard, some of you maybe hadn't. This operates on the exact same idea. Just like that bell would trigger salivation in the dog and would learn that the bell would be associated with food, we want the bed to be a place where your brain automatically, subconsciously knows it's for sleep and that's it. Okay, or sleep or sex. Not for worrying, not for problem solving, not for checking my Twitter page, which you could do, but not in bed. There are these other things that we learn over time to do that are usually compensatory. So people say, I need to read in bed, or I need to do this or watch TV in bed, and we cut that out. Sleep restriction is a misnomer. And so in our program, we call this efficient sleep, but sometimes this skill is called sleep restriction therapy. It's a misnomer because we're not actually restricting sleep. We're restricting someone's time in bed, and we're giving them a chance to get that same amount of sleep just in one big chunk. What happens with this fragmented sleep is you lose out on the ability to have deep restorative stages of sleep, which are really important for immune system. By the way, of all the skills, I think this requires the most personalization and tailoring. And so I get very guarded about apps and websites that teach CBTI and tell you to modify when you're in the bed and out of bed. I haven't seen that working really well yet. So this is especially an important skill that a trained therapist can help you monitor. Sleep hygiene, this is something many of you may have seen already. It's very often when we Google, consult Dr. Google, or ask even our doctors, what can I do to improve my sleep? Usually you're given tips, things to do, not to do, and it looks something like this. This is okay. It's one of the core skills of CBTI, but there have been dismantling studies to try to figure out of all of these CBTI skills, what works the most and what doesn't work as much. When taken by itself, sleep hygiene in comparison with active controls doesn't change insomnia. What this does is it teaches people a sense of mastery and control, which is great. And there's nothing wrong with that, but these won't cure insomnia. Every other skill related to CBTI does work for improving insomnia. When they're combined, it works the best. Sleep hygiene, it's taught with CBTI just so that you have some skills you can get mastery of, but this isn't a standalone treatment. Relaxation training is wonderful. I won't go so far as to say it's a panacea, but there are a variety of benefits, especially with sleep. And in short, what we advocate is relaxing not only right before bed, but also at some point during the day, because many of us carry stress with us throughout the day. And if you give yourself a chance to just reset your stress response in the middle of the day, it'll be easier to wind down at night. Okay, and finally, cognitive therapy. Most traditionally in CBTI, you learn about beliefs and misbeliefs about sleep. And if there are any misbeliefs, a therapist will help address it. Things like, I can't go to sleep without watching Judy Woodruff. Someone I'd worked with recently had said that, and then we sort of worked with that a little bit, and turns out now she can sleep fine without Judy. And now Judy's off the air. So, but we also sometimes learn, this is where we teach worry time as well. Okay, so those are the slides. Covered a lot of ground today talking about managing uncertainty and sleep with mind-body techniques. Also shared the CBTI skills. I want to just acknowledge, first and foremost, many of you are patients, many of you are caregivers, and a huge thank you to you for being here today, to staff at MGH and the clinicians, community partners who support this work. And I also want to thank the Vasculitis Foundation. Great. And I'm happy to answer any questions now or during the break.
Great. Thank you, Daniel. One question that had come up that people had asked before when they submitted questions ahead of time was how they could get connected to someone in psychology or a therapist in their community. Is there a good resource to identify folks like that?
Absolutely. So at MGH, we have a main referral path. If you're connected within the MGB system, there's an referral that any of your providers can directly submit through Epic or Patient Gateway. The name of the service, in case you want to message your provider and ask for this referral, it's called Behavioral Sleep Medicine. Behavioral Sleep Medicine. And if anybody has any providers in this room have a question about the Epic referral path, I'll be happy to send that to you after. If you're not seeking care within the MGB system, there are providers in private practice. There's a website with a directory. I think it's cbti.org. I can't remember the name of but I'm in the directory, and I know other clinicians who have been trained on CBTI and you can search any state and then by zip code to find providers in private practice near you. All right, thank you.